Good afternoon. First, I would like to thank the organizing committee for inviting me to share in this session. My talk is about neglected locked anterior shoulder dislocation, a new problem. My name is Professor ABDEL from Ain Shams University in Egypt. In 2005, I faced the first case of neglected locked anterior shoulder dislocation in my career. He was a 26-year-old male suffering from epilepsy, and the dislocation was neglected for 14 weeks. As you can see here, there is a glenoid defect and a humeral head defect. At this time, there were a scarce published data about this type of injury, and some treatment hypotheses were based on neglected posterior shoulder dislocation, which is more common at that time. Based on this hypothesis, I went for open reduction and infraspinal remplissage, and the results were satisfactory. As we can see here, I put one anchor in the Hill-Sachs lesion and put the infraspinatus in it. I faced another 3 cases in the next 3 years. All were young patients, and I managed them with the same procedure. One of them, I just added a letter J for reconstruction for glenoid defect. I published these 4 cases in 2010 in Acta Orthopedica Belgica. Few years later, a plethora of publications about this subject were emerged with a different management protocols. One of them I also published in 2015 on 6 cases as posterior capsular release and coracoid transfer for cases of neglected locked anterior shoulder dislocation in tramadol addicts. Another concept is osteochondral allograft transplantation for large Hill-Sachs lesion. Also a new method of treatment. Also the reversed shoulder arthroplasty in chronic glenohumeral dislocation was proposed as a new line of treatment, either single stage or double stage reversed shoulder. With the growing substance addiction, this condition is more frequently encountered. Addicts tend to experience recurrent convulsive fits, and subsequent violent shoulder dislocations. Patients usually are reluctant to seek specialized medical consultation because of the addiction problem. We have some concomitant pathology in neglected locked anterior shoulder dislocation, as you can see here. Bone defects, either in the humeral side or glenoid side, and usually both of them, as you can see in 2 different CT scans, both have glenoid and head defects of variable sizes. Stretched anterior soft tissue structures, subscapularis and capsule, especially in neglected cases, as we can talk about this in this talk. Also contracture and adhesions of the posterior soft tissues. As you can see here, the shortened of infraspinatus and the capsule, stretched anterior soft tissues. So re-establishing of soft tissue balance is essential for post-operative stability, especially if arthroplasty was the choice of treatment. Failure to regain the soft tissue balance will send the whole construct back to the previous dislocated position. So some prefer the 2 stages procedures, and also I prefer this one, is advised in long-standing cases to avoid this complication. Before starting any type of treatment, you have to check for the axillary nerve function, because if it is not working, we have a different issue. How we can manage these pathologies? First, the stretched anterior soft tissue structures. So subscapularis tendon together with the anterior shoulder capsule is carefully released with a waiver of bone for better healing later on from the lesser tuberosity. And the tendon is pulled back and fixed in place using transosseous heavy sutures with the shoulder reduced in neutral position. Contracture of the posterior soft tissues. Release of the posterior glenohumeral capsule using electrocautery is essential. This step should continue until the humeral head doesn't need pressure to rest back in place and doesn't pop up again. As regards the glenoid defect, we have many options. The most important 2 options are letter J operation. We can take the coracoid process and fix it in the glenoid to restore the size of the glenoid, or we can use iliac graft bone graft. head defect. Usually you have deep defect in neglected locked anterior dislocation. We can manage it as the first I did before in 2005 by open remplissage using 1 or 2 sutures anchors to fill this defect with the infraspinatus and the posterior capsule. Also, we can use an osteochondral allograft, the new trend, to restore the sphericity of the head. Although there's some concern about the resorption of the osteochondral allograft, and it's still working on them. As usually in some of these cases, double attack, we can treat both the humeral head and the glenoid defect together. We can use remplissage and letter J, remplissage and iliac crest bone graft, to especially in large defect in both thighs and in young patients. We have to restore stability. So reversed shoulder arthroplasty is used for a relatively old, low demand patients, or for failed of other lines of treatment. It should not be used in young patients. It provides a greater pain relief and improvement in range of motion, and of course, a better stability compared to total shoulder and hemiarthroplasty. Also, we can use it, as I mentioned before, in 2 stages, which I prefer. Some of the authors preferred a single stage. So neglected locked anterior shoulder dislocation represents a rare condition, and there is still a lack of consensus in its treatment. Each case should have a tailored treatment protocol based on the age, pre-injury function, and predominant pathology. Thank you.